Dear colleague, the case that I present today is a fetus with Beckwith-Wiedemann syndrome. The patient came to our center for the first time at 13 weeks plus 1 day to perform nuchal translucency scan. During the examination, we studied the fetal anatomy, explored in this age, and it's seen immediately that the fetal abdominal wall is not closed. In fact, by measuring a gap of about 8 millimeters, how are you looking at now? There is herniation of bowel loops covered with membranes. The omphalocele is 10 millimeters for 11 millimeters, and it's not the physiological variation as described in the literature is that the limit biometric fetal crow-wrapped leg beyond which there shall be no herniation of bowel is 47 millimeters. The crow-wrapped leg of the fetus in question is 77 millimeters, so behold the limit set. Since the omphalocele is one of the characteristic signs of the syndrome in Beckwith-Wiedemann, you go to look more closely at the move, and also there seems to be macroglossia, but in its early period is required ultrasound at 4 weeks, a time when you will get better the fetal anatomy and search for other signs of this syndrome, which are macroglossia, gigantism, renal tumors. The patient is required to perform the fetal karyotype with the expert advice of a pediatric surgeon and genetic counseling. In any case, the examination was regular with a value of nuchal translucency of 2.2 millimeters in the normal range and regular ductus venosus. At 16 weeks and 1 day, the patient returns to our observation, confirms the median defect of the abdominal wall, characterized by the herniation at the base of the umbilical cord, the bowel loops coated membranes. The omphalocele is 21 millimeters for 19 millimeters and is reported back to the patient to perform the fetal karyotype, pediatric specialist advice and genetic counseling. For gestational age, you start an even more accurate study of the anatomy of the fetus, and in particular is going to look for signs of the Beckwith-Wiedemann syndrome. This is because every time there is an omphalocele should exclude this syndrome, and it's concluded that the kidneys are regular, which is morphologically and biometrically we conclude that there is no macroglossia, and it's concluded that the fetal biometric is at the time. So there is no gigantism. The patient at this point, she was invited to perform another ultrasound, again at 4 weeks, and also perform a fetal echocardiography because we have seen from recent work in the literature that the syndrome Beckwith-Wiedemann is often associated with diseases including heart, including the tetralogy of Fallot, the patency of the ductus arteriosus, and septal defects. Beckwith-Wiedemann syndrome is a disorder of overgrowth, characterized by macrosomia, macroglossia, organomegaly, and developmental abnormalities, omphalocele. The fetuses with this syndrome have the opportunity to develop kidney tumors, particularly Wilms tumor or neuroblastoma. The estimated impact of a Beckwith-Wiedemann syndrome is 1 in 13,700 live births. is an autosomal dominant disorder characterized by dysregulation of genes in the region of chromosome 11. From the most recent literature, we learn that the risk of developing cancer is higher, about 50%, in patients with parental disomy of paternal origin. In this case, as I will explain, the patient is affected by variation of the Beckwith-Wiedemann syndrome, which presented a lower incidence of renal tumors. Now you can see that the move is irregular. There is no macroglossia. The patient returned to our observation at the 21 weeks, performing fetal echocardiography, which shows a regular anatomy and a regular heart valve hemodynamics. She shows us the investigation performed. She has performed the fetal karyotyping and genetic counseling. As the fetal karyotype is diagnostic confirmed our suspicion, Beckwith-Wiedemann syndrome, in the fetus in question, as we have noted several times, and as we are still looking at these pictures. You do not observe the characteristic signs of the syndrome other than omphalocele. There is no macroglossia, kidneys appear regularly, and also in these instances there is no gigantism because the fetal biometry is irregular. The patient has the genetic counseling and further genetic investigation required by the specialist, from which it also points to a positive maternal Beckwith-Wiedemann syndrome. The patient shows no signs of that disease, has no macroglossia, the kidneys are smooth, showing a regular hike, and no umbilical hernia. So, the patient was suffering from a syndrome that could not have, and the examinations that brought, there was evidence that the patient had the same mutation. The case we have observed and studied is a typical example of the variability of the clinical syndrome. The diagnosis of this syndrome is molecular. The ultrasound diagnosis is done with the visualization of omphalocele, the protrusion of the tongue, and the much bigger fetal biometry at the time. The polydramnios is seen in both half the cases, but in this case was regular. So, when we see an omphalocele, is recommended to search the characteristic signs of the Beckwith-Wiedemann syndrome and advise the execution of the fetal karyotype, echocardiography and genetic counseling to the mother, and investigate whether this pathology is also present in the family, as in this case. Thank you for your attention.